So I do wonder if we have to let people in.
So I think Katie's doing it from. Here we go. Right. Brilliant. Hi everyone. We'll be starting the webinar shortly. We're just waiting for one more speaker, just some technical issues, and then we'll be making a start.
Hi, Callum. I don't know if you can see that I've found my way back in. I apologise for those issues.
Not a problem. Thanks, Lauren, for letting us know. So, okay, well, I think we can make a start. John, are you okay to bring up the slide for us, please?
I certainly can. Bear with me 1 second.
No worries. Brilliant. Well, thank you all for joining us and taking the time out of your evening to see us tonight. So welcome to this webinar, The Role of Primary Care Nurses in Early Cancer Diagnosis, a collaboration webinar between Seeing the Signs and the Royal College of Nursing, particularly between our RCN Cancer and GPN forums. So just some housekeeping for tonight. As you'll see, you won't have access to camera or microphone, but don't worry, we do have the Q&A function enabled tonight, which you see at the top of your screens if you want to ask any questions throughout, and we'll be trying answering some of them as we go, but it might be towards the end when we have the Q&A session, we answer those as well. We'll also be using Slido at the end for you to ask any questions after the presentation tonight. So I'll start with some introductions first. I'll tell you who I am. My name is Callum Metcalfe O'Shea. I'm the UK professional lead for long-term conditions here at the RCN, and I'm still working in primary care as an advanced nurse practitioner. So really excited to see this and be involved in this presentation tonight. I'll hand over to John for the next introduction.
Hello, thank you very much for that, Callum. So my name's John Woolley. I'm here representing See the Signs, so I work with them as their clinical lead. I've got a sort of quite an extensive background in primary care. I'm still a GP and I work in the West Midlands. I'm really looking forward to having a chat with everybody about cancer and how we can detect it earlier.
Brilliant, thank you. Lauren.
Yeah, thank you very much. Hi, I'm Lauren Dollive and I'm excited to be here tonight. I'm here to represent the Cancer Forum for the Royal College of Nursing, where I'm vice chair, and then in my other job I work in the Cancer Alliance at South Yorkshire and Bassett Law, and my background is an advanced nurse practitioner where I've worked in primary care and in oncology, of course.
Thanks, Lauren. And Frances.
Hello there, everyone. Thank you for hosting this tonight. My name's Frances. I'm here as a representative for the RCN Practice Nurse Forum, General Practice Nurse Forum. I still currently work within general practice in the north of Wales.
Brilliant, thank you. I'll hand over to Lauren now to give you an overview of the Cancer Forum.
Yeah, so this is just a bit of background as to kind of what the Cancer Forum is, if you're not already involved. I get a bit of a kind of please do think and consider being involved. So we've got over 6,700 members now. We're trying to represent the nurses working across the UK, all 4 countries, both registered and non-registered staff. So we kind of work and we undertake different projects at the moment. Obviously, we're looking towards that kind of generalist viewpoint and expanding that kind of confidence and competence amongst generalist nurses, but we do all sorts of other things like get involved in clinical consultations and kind of get involved in policy and clinical resource development. So there's a bit of a background to that, but if you want to know more, we've got some websites. We work really closely with Macmillan and Cancer Research UK and UCONS. So it's just that kind of background. So there's lots of our members hopefully might have thought about coming tonight, but if you're not a member and you'd like to be, please think about joining. So I'm the vice chair, Callum's professional lead, and we've got the lovely Hayley, who's our chair. So it's a nice friendly team, and you'd be more than welcome to join us.
Thanks, Lauren. And I've just popped in the chat there the link to the Cancer Forum for those who haven't seen it, and I'll hand over to Frances.
Thank you. So the RCN GPN Forum, lots of letters, represents all of the nurses who work within general practice across the 4 countries. We really do focus on trying to align all care so that everyone manages the same condition, can have the same access to resources. We also look at education that's out there, resource development, but one of the biggest things that we're doing at the moment with the forum is the fair pay. So fair pay for general practice nurses, because as many of you know, if you are in general practice, we're not aligned to Agenda for Change. So we're lobbying a lot for that. We've got a very active Facebook group, which is a closed, safe group. So you're more than welcome to join that. You just need to search it on Facebook, which is monitored through the forum. And we've got, as you can see, a very active forum with over 10,000 members. So please, if you're not already a member, do just click that button and join us and keep in touch with what we're doing. Many thanks.
Brilliant. Thanks, Francis. So now, before handing over to John tonight, I just wanted to talk to you about this slide that shows the RCN 5 levels of nursing practice, and these each have distinct responsibilities and escalation pathways. And really, this is to help you understand your role in primary care when supporting patients living with and beyond cancer. So you see we have the different levels, and so for example at the supported level around HCAs and supportive workers, they'll be delivering that essential care under supervision and escalating any concerns to the registered nurse. At assistive level, these will be working in addition to the supportive level descriptors, where staff have a deeper level of knowledge, skills and training, but again working with a registered nurse and escalating any concerns where appropriate. And then at the registered level, so practice nurses will be clinically accountable, identifying any possible signs and symptoms, and again they may need to escalate any concerns to that enhanced, advanced or GP level. And at enhanced level nursing, this is where nurses may have prescribing rights or specialisms that may offer advice and treatment, and again may need to escalate to ANPs or GPs. And then finally our advanced practice level, which is where ANPs are leading care in complex situations, prescribing, treating and referring independently. So this slide can be used to help support you in practice around your role responsibilities and throughout this presentation tonight when thinking about your vital role in primary care. I'll hand over to John to take you through the rest of the presentation. Thank you.
Brilliant. Thank you very much. Just to sort of set the scene a little bit for everybody, the first 10 minutes or so, I'm just going to give a bit of an introduction into cancer in general and why early diagnosis is so important, but also why it's so challenging in primary care. And the main reason for doing that is to try and ultimately help people feel a bit more supported, a bit more clear, and have a bit more clarity about how they might want to look at, manage, and if necessary, escalate a presentation of a patient that you might be seeing. I'm going to try and keep it quite broad. And I think the joy of having sort of a number of colleagues on this call with me is they will, when we get to the case study bit, they'll prompt me with some questions and we can have a little bit of a discussion. And I would encourage people, if particularly during the case study section, you've got any particular bits that you'd like clarification on or any particular queries or questions, please do use that, because we want this to be as useful and as insightful as possible for everybody. So I'm just going to sort of zoom out to start with and just talk about cancer in general. We know that across the UK, about 400,000 patients will get diagnosed with cancer each year. And despite the fact that there's been massive improvements in the way in which we treat cancers, so whether that's radiotherapy, whether that's chemotherapy, or whether that's surgery, or some of the many other different treatments that are now available to patients, for many cancers, the actual outcomes for patients has not really improved. And the main reason for that is the fact that we still, particularly in England, but across all of the devolved nations, we tend to detect cancer too late. There's a national target in England for 75% of cancers to be diagnosed early. At the moment, we achieve about 58%. And the reason why this is so critical is that when we detect cancers late, so that's stages 3 and 4, patients have a 5-year survival of less than 30%. Yet if we can detect their cancers really early, they can have a 5-year survival of well over 80%. And so that's why early diagnosis is so critical. The other interesting thing about the way in which cancer is impacting us is that we're seeing many more cases of cancer in younger people. So we know 40% of cancers are diagnosed in those under 65, and we're seeing a particular increase in cancers affecting people between the ages of 25 and 49. And that's something that I've seen, and it's quite staggering to me how that is happening and why that's happening. And so we've got to keep our eyes and our ears and our radars really on high alert, even when we're consulting with patients that we might not necessarily think of as having cancer. The big thing, though, that I want to stress is that most patients with cancer will present with a symptom. So about 95% of patients will present with symptoms, and that does give us a real opportunity to impact. The question is, where can we impact? And I just want to briefly talk us through sort of the trajectory of somebody who gets diagnosed with cancer, just to stress the importance of early diagnosis and where we can intervene. If we think about things at the very earliest stages, we're talking about people who've got cancer and they don't even know it, so they don't have any symptoms. And the way in which we can try and help detect these patients is through screening programs. And we'll all be aware there are some major screening programs for cervical, breast, colorectal, and in some parts of the country, there's now targeted lung health checks. But these actually only detect 5% of all cancers across England. The good thing, though, is that when we do detect cancers here, we often pick them up at a very early stage, at 95%. And that means that patients picked up here have really good outcomes. What that means is that when we're consulting with people for anything really, we often get pop-ups saying cervical screening due or eligible for this screening test. It's really important to try and engage people at this point, because even the littlest of conversations can often convert someone who might not attend screening into attending screening. So that's a really important thing just to be aware of. The other sort of section really is once we move from the asymptomatic stage, we move to the point where patients begin to be aware that they've got symptoms. There's not a huge amount that we can do here directly from primary care, because often this is about an individual choice about when somebody's going to present. Often it's when their symptoms get really bad, that's the moment that they might attend primary care. Or it might be that a loved one is saying to them, hang on a minute, I think you should go and get that checked out. And so here, things like public health messaging, general patient education, all become really important. The bit that perhaps is most interesting to us on the call today, though, is when a patient decides to seek primary care help. We know it is incredibly challenging at the moment for patients to access primary care. We know that there's loads of reasons for that. And that means that when patients do get through the front door and we're consulting with them, it just actually pops a bit more pressure potentially on us. We know that 45% of patients with cancer doesn't get picked up on their first appointment. And we know that for many people, 20%, they will see their GP or a primary care professional at least 3 times before they get referred. And we know this is particularly worse for certain cohorts, so ethnic minorities, transgender population, just to name but a few. These people tend to have poorer access to primary care. Just got to be mindful of that. Once somebody's been seen in primary care and we've referred them on, there's often delays, unfortunately, with getting patients seen. We know that in England and across the UK more widely, access to imaging and things like endoscopy, camera tests, really quite challenging. And this is the worst case scenario where a patient actually doesn't get picked up in primary care at all. They actually get picked up in the emergency department. And sadly, 20% of cancers still get picked up in this way. And when we look back in time, 66% of them have actually seen their GP or somebody in primary care in that preceding time. And the reason why early diagnosis is critical, and this is just an important thing, every month of delay to that person getting treatment increases their mortality by about 10%. And so every month of delay has a real impact on a patient. And so the purpose of today is just to try and get our radars up and perhaps a bit more confident in knowing when to escalate. Why is it a challenge for primary care? I speak as a GP. On average, somebody like me will see 8 new cancers a year. And for some rare cancers, I'll only see 1 in my career. That makes it really, really, really challenging, actually, to be really good at pattern recognition. And actually, cancer is a multitude of different conditions all rolled up under one term. Let's just think about a patient for a moment, presenting with a cough. They might say they smoke. They might say they feel tired. They might say they've got a bit of appetite loss, and they might have a bit of back pain. That's a multitude of different symptoms, some of which are broad, some of which are specific. And when you think about all the different ways in which a patient might present, there's a lot of things there, and it can be very difficult to try and differentiate between what's serious and what to do. And just to flick on to a couple of cancer guidance diagrams. The one on the left of your screen is from Cancer Research UK. The one on the right is from the BMJ. And what these just illustrate is how complicated it is to try and take a set of symptoms and extrapolate that to a particular cancer. It's like a bowl of spaghetti. So the reason why I'm passionate about this particular topic is because I really feel that there's lots and lots and lots of ways that we can help. Digital solutions are part of it, and I'm here speaking on behalf of See the Signs. And See the Signs is a company that's been around for 7 years. What we do is we create software to try and help people working in primary care detect cancer at its earliest and most treatable stages. Throughout the case study, I'm just going to sort of illustrate how See the Signs works, because at the backbone of See the Signs is a risk assessment tool which combines information that's contained within the electronic healthcare record with symptom information that you as the clinician pop into it. And then behind the scenes, See the Signs will do some clever stuff, and it will then provide you with some actionable advice in the form of recommendations about what you might do. And I will demonstrate that in a second. We help in a number of other ways, which if we've got time at the end, I'll go through. But the main thing that I wanted to try and put across here is the way in which digital solutions can perhaps help try and untangle some of that spaghetti that we saw previously. I'm just going to show a very brief video, and then we'll move on to the cases. So that's just to illustrate really what See the Signs is all about. But now let's move on to talking about some case scenarios. So myself and Lauren are going to tag team this. So I'll hand over to Lauren now.
All right, that's great. Thanks, John. So we'll go through the first case, and I'll tell you a bit of information. So first, we tried to sort of think of presentations that you might see. So hopefully you'll recognise some of these patients, so you can picture them in your head. But first patient is David. He's 61. In terms of his background, he's got high blood pressure, for which he takes amlodipine and ramipril, and he takes a statin. He has had recent bloods on his cardiovascular screen, which were fairly normal, so normal liver and renal function, and his full blood count had a slightly raised white cell count. Everything else looks normal, and he's just coming in for his regular hypertension review. Blood pressure's controlled, and he's got no symptomatic kind of presenting concerns, so blood, nothing to do with his blood pressure or his urological systems troubling him. But when you check his urine as routine, you notice that there is blood on the urine dip, and as you kind of repeat them to sort of check that it's resolved, you notice that that's confirmed. So he hasn't got any clinical signs of infection. He feels all right, but the blood resolves. So what we're going to ask you to do, just to try and hopefully make it more interactive for those of you that are able, is if you would like to sort of take a look, and up at the top bar where there's the react smiley face, you should be able to find the kind of emoji that represents the next step. So you can, this will be the same throughout. So the kind of, if you would like to have a little look and see the options. So what would you do as your next step with David? Would you monitor him as, he's got no symptoms, keep an eye on him? Would you repeat the bloods in a month's time? Would you think about giving him some antibiotics? Send him over to urology with a routine referral, or would you look towards an urgent suspected cancer referral to urology? So I can see quite a lot of reactions here, which is great. So people are getting that, so that's great. Hopefully it just gives us an idea of people interacting and things. So that's the scenario, and I'll hand over to John to sort of say what we might do next and why.
Brilliant, thank you. So I have to admit I missed some of the emojis, but I think I saw quite a few for the urgent suspected cancer, and there may have been a few for the routine urology referral because of the non-visible blood, and they are the most common sort of answers when we ask this question. Now, the answer is the urgent suspected cancer referral to urology. And there's one particular thing on this case which is the key factor behind why it is an urgent suspected cancer referral rather than the routine one. And that is in the case of the white cell count, which is quite raised. We know that bloods, particularly full blood counts, there are two main markers that we're interested in from a cancer perspective. One are the platelet counts, because there are some cancers out there where platelets, raised platelets will be associated with cancer. And that's because it's an inflammatory marker. It shows that there's some form of inflammation going on in the body. But interestingly, for urological cancers, and particularly the bladder cancer, raised white cell count in its own right is quite an important factor. So just to sort of reiterate this really, what I'm sort of presenting here and what I'm showing here is the urgent suspected cancer guidance, which many of you will be familiar with, comes from something called NG12. So NICE Guidance 12, that's sort of the holy grail when it comes to advice on what to do with cancer symptoms. And the key thing here is that anybody, so this could be male or female, over the age of 60, with painful wee, and a raised white or a raised white cell count in the presence of non-visible blood, you should be considering and thinking about an urgent suspected cancer. It goes without saying that we should rule out urinary tract infection. So that is really, really, really important as an opening gambit. And on this side, I've just sort of popped a definition of what we mean when we say persistent non-visible hematuria, because it is quite a nuanced thing. And I know whenever I dip urine and you see a couple of traces of blood and you think, oh gosh, what on earth is going on here? Because it's quite a painful thing trying to get somebody to repeat it and bring it back time and time again. But the definition here is the presence of blood on a urine dip on at least 2 out of 3 occasions without there being an obvious other cause for it. And where you don't have the cause but they're under 60, then that's where you should consider referring somebody in a non-urgent manner. And in younger people, so often below the age of 40, then we begin to think of the kidney as potentially being the source of the blood rather than the bladder. Is there anything that you would ask me, Lauren, or anything that you'd want me to sort of clarify on any of that?
Yeah, I think that's pretty clear, John. I wonder if would it be the same if we found some blood in the on an MSU result then that we sent?
Yeah, so it's a good question. So yes, it would be. We know that a urine dip is often more accurate, believe it or not, when it comes to detecting blood than an MSU. So the presence of blood on a urine dip, even if you don't find blood on the MSU, we should still class as non-visible blood. But yes, if for some reason you've not detected blood on the urine dip, but you do find it on the MSU, then yes, that you should class that as if you picked it up on the urine dip.
Thanks.
Well, I'm just going to very briefly at this point, just going to quickly flip over to see the signs for a second, and just to sort of show you what would happen in this scenario if you were to use See the Signs. So See the Signs is a risk assessment tool. And there are a number of different ways that you can get this to work, but this is the commonest way, where you would click on the body system that you are worried about. If you work in England, we have an integrated version of See the Signs, so it would detect the correct patient from the electronic healthcare record and bring in their age and their gender, so that all of that information would come in, and then it takes you through quite a logical way of assessing a patient. So have they got any urological risk factors? Are there any active infections going on which are highly relevant to the urological system? What symptoms have they got? What signs have they got on examination? And what investigations have they got? And I just want to show you how it would perform in different scenarios. So if we were just to put in hematuria, non-visible, and then we clicked risk assess, what would happen is it would give us the recommendation that this person does not meet the criteria for investigation or referral, which is technically true. If we add in, however, so I just need to pop back in 61 of male. If we added back in though the raised white cell count and then clicked risk assess, what would happen then is it would correctly detect that person has triggered the NG12 guidance for a urological referral, and it would make that recommendation. And then if you were working in England and you had our integrated version, you would just click this checkbox here, and it would give you the option of going directly to that referral form if you were a referrer. We often find that people use this system as a sense check. It's particularly useful if you're seeing somebody with sort of vague symptoms. So if you wanted to sort of put in something like weight loss and then click proceed, what it would do is it would pick the body systems where weight loss is a significant factor from an NG12 perspective, and it would just increase the options in terms of risk factors, signs, symptoms, and it would then encompass all of these different cancer systems, so that you know that you've got the best advice that you can possible. So I just wanted to demonstrate that there, just to show how it would react in that particular case. So I'm just going to go back to the slides and we can go on to our next case study.
Brilliant. Yeah, Thank you. So the next case is a different one. So a woman, this time it's Zara. She's 39 years old, and in terms of a medical history, nothing of much significance. So no big medical history, no family history of colorectal cancer. She's a non-smoker, an occasional drinker. BMI is 26, and recently she had some bloods done for fatigue, which were all normal. So she had full blood count, thyroids, and a CRP. But she comes to primary care with 6 weeks of lower abdominal discomfort and bowel habit change. So she's having intermittent constipation and loose stools. No visible bleeding rectally, and she just says that her fatigue has got worse over the last month, but she has got quite a stressful life and children, which lots of us can probably relate to. So if you can think of a patient like that, get them in your head and then think about what you might think of doing next. So it's the same thing with the reactions and the kind of emojis here. So are we reassuring? Are we referring urgently? Are we going to think about doing a fit test? Are we going to prescribe some symptomatic management if we can, or seek advice on that? Or are we thinking about a non-urgent gastro referral? So we've got lots of very similar answers here, a couple of different ones. So some who are going to kind of give some symptomatic, some who are looking towards a non-urgent referral, lots of people looking towards doing a fit test. John here.
Yes, and I think the key with this one is the reality is you probably do a couple of things here. So you wouldn't really just do one thing and then call it a day. And my glance across, I could see there was quite a lot of clapping hands, as you said, so requesting a fit test. And there were a few people quite reasonably, I think, would be suggesting some symptomatic treatment. So that tended to be the main answers. The answer, with the context of what we're talking about today, is request a fit test. And there's a number of little things that have changed over the last few years, really, which have just reinforced that as being the sort of a really critical and key thing. Just to sort of zoom out a little bit, and just be clear what we mean when we talk about fit. In sort of 10, 15 years or so ago, we used to have a test called a fecal occult blood, which many of you will be familiar with, which was where you wiped yourself, you then sent it off. It was a bit of a faff. It wasn't always that great, and people tended to not really like filling them in and doing them. And more recently, we've used this fecal immunochemical test, which is a really, really, really brilliant way of detecting the presence of blood in poo that's not visible to the naked eye. And it's become a really, really, really useful test for a number of reasons. The main reason being that it is brilliant at ruling out cancer. It's got a really high negative predictive value, something like 99% of patients, if they have a negative fit test, they will not have a colorectal cancer. So it's a brilliant way of ruling cancer out. And it's revolutionized the way in which we access colonoscopies, so camera tests looking in the bowel, and also the other types of imaging that we do to look at the tummy. And it's now an essential part of a referral to a lower GI person. It's also significantly more accurate at picking up cancer. So a positive fit test is far more likely to detect cancer than just using bowel symptoms. So somebody presenting with sort of tummy pain and diarrhea actually is not that good at picking up bowel cancer alone. And so bringing together a fit test alongside looking out for those really significant risk factors such as weight loss and rectal bleeding have revolutionized the way in which we detect cancer. The thing that I've put on here in the table, though, is just to make people aware that there are two scenarios where we use FIT. There is a colorectal screening program, which is really important to be aware of, because a lot of people will have a screening test, and they will have a negative screening test, which is great. But it's important to be aware that the screening cutoff for a positive fit is significantly higher than it is if you in primary care send somebody off for a fit test. And there's a lot of reasons for why that is, but it's because primarily that when you're doing a screening test, you're doing it in a population that don't have any symptoms. Therefore, the chances of you picking up colorectal cancer are much less, and therefore NICE, who make these recommendations around and the screening program, they've set it at a much higher level. When you provide a fit test to somebody in primary care, a positive fit is anything over 10, and that's obviously significantly less than the screening cutoff. So the key message here is just don't, if somebody presents to you with symptoms that we're going to talk about in a second that would warrant you to request another fit test, don't be put off if they've had a screening test done and it's been negative. Do request the fit test again. It's really important that you do that because you will help pick up cancer in that population.
Brilliant.
The other thing, oh, sorry, Lauren, go for it before I go on.
I was just going to say, so we wouldn't be kind of reassured by the fact that Zara's quite young in this situation, would we?
We wouldn't, absolutely not. And I think that particularly because we are seeing that increasing incidence of colorectal cancer in the younger population, it's a non-invasive test. It's generally viewed as being quite acceptable to most people, although obviously we do need to be sensitive and in the way that we describe what a fit test is and what they're going to have to do. But it's brilliant at just ruling out cancer, and certainly the new changes which updated in NICE in a couple of years ago really expanded the role of fit in a number of different cases. So in younger people, definitely it's something that's much more advocated, but also, and this is important, there used to be a belief that if somebody presented with rectal bleeding, there was no point in doing a fit test. What we actually know is that having actual fresh blood does not impact the fit test. It's looking for a different component of blood, and so if somebody's presenting with symptoms that might make you think of a wider tummy problem, don't be afraid of using a fit in those scenarios as well. You might look for a pile, and you might look for an explanation, and you might even refer them on the basis of their rectal bleeding, but don't let it stop you requesting the fit test, basically. Anything else that you'd want to add or ask me, Lauren?
Yeah, just to reiterate the same thing. Yeah, we're just significantly higher incidence in younger people, isn't there, these days? So yeah, absolutely. Thank you.
Yeah, just be aware of it.
Yeah.
Brilliant. I'm just going to actually skip this one, and we're going to go on to another case.
Thank you, John. So this patient is Mark. He's 52. He's from Afro-Caribbean ethnicity, and he has no family history of prostate cancer. So it's a case that relates to PSA. So he is a smoker, smokes 5 cigarettes a day and drinks 14 units. He has got mildly elevated BP and cholesterol and is fit and active, working full time. And you're seeing him for a NHS health check. So he's not come in with any symptoms, but during the conversation when you're doing his bloods and his checks and things, he asks you about a PSA. So he wants to know, should he be having a PSA? He's had a friend recently diagnosed with prostate cancer, and should he be having one? He wants to know, and if you can react in the with the react button, that'd be brilliant. So what do you think we should say to him? Reassure him that he's not got any symptoms, so he shouldn't need a PSA. Go through the pros and cons with him of PSA testing and offer him one if he wants one, and think about why that might be if you want. Would you refer him directly to urology for further discussion, or would you put him through to an advanced practitioner or a GP for a digital rectal examination to see if his prostate feels normal?
Brilliant. And again, I saw a lot of hearts in there. And I also saw a couple of thumbs up as well, which is a really, really, really important sort of distinction, really. And PSA as a concept is quite a controversial one. And in this scenario, and we'll talk about why in this scenario in a second, it's quite important that we do offer a PSA test. And it's primarily because of this person's risk factors, and we will talk about those as we go through the case. I just want to sort of touch upon what PSA is to start with. So PSA is a particular chemical that the prostate glands, which obviously is only present in a man, will release into the bloodstream, and anybody with a prostate will have some level of PSA in their bloodstream. We've offered PSA testing for quite a long time, but there hasn't yet, and I say yet because this is an evolving an evolving area, but there isn't yet a screening program which uses PSA to try and detect prostate cancer. And one of the reasons for that is what I've put up on the screen here, is that PSA, while it is useful, and it's probably the best marker that we've got in primary care to help navigate us towards prostate cancer, it isn't the best test in the world. Partly, and this is because it's not that sensitive or specific. So what you're seeing on screen here is that for men who have a normal PSA, so a PSA below 3, about 15% of them actually do have prostate cancers. So whereas with a FIT test earlier, I was saying if it was negative, you could be really confident that that person hasn't got colorectal cancer. It's more difficult to say that with a PSA test. The other thing to say is that when men have raised PSAs, obviously the higher the PSA, the greater the association with cancer, but it's still not massively high. So there will be many men that we refer for further urological investigation who have raised PSAs and do not have prostate cancer. And therefore they're put through invasive tests like biopsies and things unnecessarily. And that's always been the argument behind why there's not been a screening program. It is changing because there's lots of research going on at the moment looking at MRI scans, probably in combination with a PSA test. But there's lots of studies going on at the moment. And so as someone who sees a lot of men where discussions around prostate cancer are really common, I would love there to be an effective way that we could sort of detect these cancers appropriately, much more effectively than we currently do. Just very briefly, I just want to talk about another thing, which is the DRE examination. This is my rubbish drawing of the male urinary tract system. So what it shows is the ureters sort of sending the wee from the kidneys into the bladder being the storage unit, the urethra being the pipe to the outside world, and then the prostate, which sits beneath the bladder, and it basically goes around the water pipe. And so when men present with lower urinary tract symptoms, so things like hesitancy, poor stream, those sort of things, you can see why that might happen if the prostate was getting bulky, if it was compressing that water pipe. What you tend to find with prostate cancers, though, are that they actually sit on the outer capsule of the prostate. And unless the cancer is either very, very big or very, very close to where that water pipe is, it's not actually going to cause symptoms. And so there actually is very little evidence to say that a lower urinary tract symptom is particularly associated with cancer. And so in itself, it's not necessarily that alarming. The other thing to say is that a DRE, so that's the rectal examination, it used to be said that a man presenting like our case, we should 100% do a rectal examination as well as a PSA test. Remember, he doesn't have any symptoms at all in our case. There's increasing evidence that the thought of and the fact that we do quite intimate and invasive examinations actually puts off a lot of men attending about their prostate symptoms. And so for a man who doesn't have any symptoms at all, actually it is reasonable to do just a PSA test without that rectal examination. It is reasonable to do that. But in any man where they do have symptoms, I would still recommend doing that examination because you want to detect those other things. So that's just sort of describing a little bit around prostate cancers and how they might present symptomatically.
I feel like the evidence is sort of changing our clinical practice, isn't it? Because I certainly feel like that's a significant change over the last few years, isn't it? In what we were advising and talking to men about, isn't it?
Yeah, and it's all part of that counselling stage of trying to, because it is important to be honest about PSA testing and the benefits and the potential harms of it. In my experience, most men, if they've made the decision that they want to actively attend for a PSA test, will go ahead and have a PSA test. And that's why this slide is really, really, really important, because it's often the men that come in asking for PSAs don't classically fit into these categories, because what we know is that there are very, very, very significant risk factors for prostate cancer. So 1 in 4 men who are of a Black Afro-Caribbean ethnicity will get prostate cancer. That's really quite significant. Somebody that's got a first-degree relative will have a 2.5 times more chance of getting prostate cancer than somebody that doesn't. And so if nothing else, those 2 groups of people are likely to be the focus of screening programs moving forward. So rather than it necessarily be every man gets a PSA or an MRI scan, dependent upon how the screening evolves, we just need to be mindful that men who are Black Afro-Caribbean ethnicity and a very high risk. We also need to sort of delve a little bit into that sort of family history, and certainly a man asking about prostate tests. These are key things that I will be looking to ascertain. And the 83%, it's stuff from Prostate UK. There's a huge, I mean, most men who are at risk don't know they're at risk of prostate cancer. So there's a big public health type thing that I think we should be doing. Any other questions, Lauren, that you want to pose at me at this stage?
I was just going to say, I guess there's an opportunity here to sort of have those sort of nudge conversations with people who do fall into that high risk category, because if it's not certain what's going to happen in terms of national screening at the moment, but it certainly is a conversation that's a fairly hot topic at the moment, isn't it? So as things are changing, it's just to have that at the back of your mind, I think, around that kind of who is more at risk, and those conversations, those touch points that you can have with people with prostates and around their potential risk, even if it's just conversationally, and we can direct them to some of the resources available. I think Callum's put one from Prostate UK in the chat, but I think it's just an opportunity that we can potentially go looking for those ones, again, the high risk ones, that the kind of the more aggressive prostate cancers. Lots of prostate cancers, of course, not as dangerous, and many men live a very long time with them, and they don't actually impact on their kind of mortality, do they? But yeah, just to mention that.
Brilliant, thank you. So we've got about 10 minutes left. So if we sort of go through this case, and then we'll give opportunity to go through any questions and wrap things up. Go for it, Lauren.
Yeah. So this is Maureen. She's 62. She's come in for a routine cervical screening, and as you're kind of talking to her during the pre-screening discussion, she does disclose to you that she's had a bit of bleeding in the last couple of months. Nothing too heavy, but some spotting, and she remarks that it's odd, you know, a long time since she's last bled, and she don't want to make a fuss, but she just thought it might be worth mentioning. She is not currently on HRT. She stopped that 3 years ago. She's not had any surgery of note, and she just takes amlodipine for her blood pressure. And I was just wondering, what would you do in terms of next steps with her? There's a few options here. Would you carry on, do the smear and keep an eye on the bleeding? Would you complete the smear and arrange for her to see a kind of clinician afterwards? Would you defer the smear and send her for urgent assessment to find out what's going on with the bleeding? Or would you reassure her, like, bleeding can happen from time to time? Lots of hearts, I'd say, here.
I'm seeing quite a few hearts,
claps.
quite a few claps, and that's definitely sort of, again, that is sort of where I would have expected, or where I was expecting the answers to be. If we're going by the letter of guidance, then it's defer the smear and advise an urgent assessment to uncover the cause of bleeding. We'll talk about very briefly about why actually complete the smear and arrange a routine follow-up might be appropriate, although we could probably, if we change that to urgent, then that's probably going to have the same effect as the one beneath it. But the key thing here is that this woman has disclosed that she's having odd bleeding, basically. So bleeding that she wasn't expecting. It's not bleeding after sex, although from the history, it's not necessarily, you can't 100% say that. It's quite a key differentiation in terms of where the bleeding might be coming from. So post-coital bleeding or bleeding after sex tends to be more associated with cervical pathology, whereas other types of bleeding, we're more thinking about womb cancer or endometrial cancer. The reason why people often advocate for deferring the smear is because some people believe that actually a smear test is going to uncover the problem. And it's really important to remember that a smear test is a screening test. It's looking very, very, very specifically at the cervix. And in this scenario, we need to think about a diagnostic test. And actually, that's likely to be something very, very different. I do think it's reasonable to complete the smear as long as somebody is then sort of reviewing them with a view to why is this person bleeding. There's no evidence that the smear result is going to be impacted by bleeding, but I think it's just the premise that we need to do something to uncover this.
You don't want to give false reassurance in that scenario. Is that what you mean?
100%, yeah. And I think the thing that's really important, particularly as more and more and more women are on HRT and often on HRT for many, many years, we are seeing quite a lot in primary care of bleeding that is a bit odd, doesn't quite fit. And so there's been some really, really, really recent and quite important guidance from the British Menopause Society around what are the type of factors and symptoms that would make bleeding a bit more worrying, and where we should really be referring them on for diagnostic tests, which would be ultrasound scan or a scraping of the womb, as opposed to the scenario where actually we need to adjust their HRT medication. So they're divided into major and minor. If there is a major risk factor, regardless of whether somebody's on HRT or not, they should be referred onwards. So that's high BMI, genetic predisposition, and then there are some quite specific types of HRT which would be classed as major risk factors. Minor risk factors, so if you have 3 or more of these, then they should be referred onwards. That's overweight, but not very overweight. Unopposed estrogen, so that's where there's no progesterone essentially given alongside the estrogen. Conditions like polycystic ovary syndrome, diabetes is classed as a minor risk factor. And so it's just being mindful that when you're assessing bleeding, and this is the case of any age, but particularly in the postmenopausal age woman, these are the type of symptoms that you should be asking about and will be quite important when it comes to deciding what to do next. Anything else you'd want to ask me, Lauren, on that?
Yeah, there's a question in the chat that's pretty pertinent, I would say, just in terms of bleeding, the kind of current guidance suggesting that bleeding can give a false negative cervical screening result, and that the current guidance is saying that should be deferred and postponed if the patient is currently bleeding. I guess that it depends on the way that we interpreted that history, I suppose.
Yeah, and I think the key thing here is the most important thing is we need to know why this person is bleeding, and so we don't want to do anything that's going to interfere with that process. And so I just think the most sensible thing to do in that scenario is to focus entirely on what do we need to do to diagnose this cancer or not, as the vast majority will be, and then the screening component can be done at the most appropriate time. So I think that's a very fair point.
Thanks.
Brilliant. I'm just mindful that we are very close to the end, so I'm just going to quickly skip to the end of the slides. Bear with me. There we go. So I hope people have found the session useful. I hope that there's been some interesting nuggets of information for people to sort of take away. It isn't easy working in primary care at the moment, and there's a lot of pressure on everybody. And I think the key message above all else is, I think generally speaking, primary cares have got a brilliant team ethic. Everybody's got lots of different experience and lots of different expertise now in primary care. So I think it's really, 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 really important that we do use the vast knowledge and skill mix that we've got across primary care. Clearly, I strongly believe that things like See the Signs will help us, give us peace of mind, will help with some of our diagnostic and decision making, and that's what it's there to do. It's there to try and help and support everybody in primary care. And I think what I would say is, if we've got time now, we'll obviously have a look at the chat and take on some questions. And I'm really keen for any feedback. I'm sure all the team are as well. So do feel free to sort of scan that QR code, and that will take you through to a feedback form, which would be really grateful to get some of that feedback on. We will, in our follow-up communications, probably send a copy of that link as well, just so that you don't feel, if you haven't got your phone handy, don't worry. But yeah, I don't know if there's any comments or things, or any queries or questions that have cropped up just before we let people go.
Yeah, John and Lauren, first I want to say thank you for a great presentation, some really useful case studies, and I definitely know I've learned loads tonight when I go back to my practice, so thank you very much. Yeah, we've had some good conversations in the chat. There's one question particularly from Sophie I thought would be really useful to go through at the end, and Sophie had asked, we are taught to not do a urine dip on anyone over the age of 65 or with a long-term catheter, as it can show false positive results. What urine testing could we do in this situation?
Oh, it's really difficult. Really difficult, because my own take on it is I try and avoid urine dips in that scenario, as I'm sure everybody does. There are clearly time and a place for them, and I think the key thing would be is that, as with all tests, what are you doing it for? Is a urine dip going to give you the answer that you're looking for? So if you're doing it specifically to look for the presence of blood because you were worried about a bladder cancer, then I would be questioning, because it's going to show a bit of blood almost certainly. So I think it's managing that reality and thinking, well, what else do I need to do, and not putting too much store by the urine dip. Probably in that scenario, but it is very, very challenging because they all show leukocytes and blood, and we've all been there and regretted doing it because you think, well, what do I do with it now? But yeah, it's a great question, and I think that's one of those where a conversation about what the best course of action might be is going to be key.
Brilliant, thank you. Yeah, and there was another question in, or sort of someone had asked in the chat if anyone had done any routine dipping of urine on the hypertension reviews as they're sending for UACRs. And I just know from my practice, it's not something that we routinely do. But as you say, I think it's, as you've mentioned there, depending on the patient, the situation, the scenario. So no, thank you for answering that.
Pleasure.
So I think from a question perspective, that was one of the questions that we had unanswered, because I know you'd answered the bleeding one during the case study, which was really useful. But as I say, mindful of time, but if there's any last minute questions, please do submit whilst we've got the expertise of John and Lauren on the call particularly.
There's just one in the chat about requesting kind of the CPD certificate for the event. Callum, I wonder if we might mention that.
Yeah, so I believe after this event, I know Katie might have said we will be contacting individuals which will have a webinar recording, and John, I believe there will be an opportunity for a certificate after this, won't it?
It will, yeah. So just in terms of the certificates, what will happen is it probably will take 28 days. So the process that goes on is we submit this sort of presentation to the CPD accreditation team, and then they sort out the certificates for us. So as long as we've got your name and as long as we've got your email, you will get a certificate out via email, and I would expect that within 28 days. So we'll make sure that happens.
Brilliant, thank you. And I can just see one last quick question is, what would be a significant weight loss in a routine review with a nurse?
Wow,
big question.
What a question to finish off with. My gosh. I'm going to slightly fudge the answer because there is no absolute figure. It's genuinely about the person that you've got in front of you. It depends on, are they on a weight loss medication? And we will see quite a lot of people that we may be not expecting to losing weight, because a lot of people are getting this type of treatment on privately. But I think for me, when somebody is coming in complaining of weight loss, when their clothes are clearly not fitting properly, they're key things just from an observation perspective. And in my brain, I look at 10% of their sort of body weight as being that's a significant drop to make me think, hang on a minute, what's going on? And if I don't have an explanation for it, that's my rule of thumb. But there will be scenarios where less than that will prompt me to be worried, because it's in combination with other things.
Yeah, where it's unintentional, and that kind of clinical intuition is telling you there's something wrong, isn't it, as well?
Oh yeah, and weight loss is one of those really challenging symptoms to unpick, because it can be a sign of so many things, but it is a really important sort of on that radar of, hang on a minute, something's not right. Unintentional weight loss is right up there amongst the biggest ones, so it needs to be taken seriously.
Brilliant. Well, thank you, John. So I think that brings us to the end of our webinar now with those questions. So I'd like to say again, thank you to See the Signs and for the RCN Cancer and GPN forums for tonight for this collaboration webinar. Really hope you all found it useful. As said, Katie's mentioned in the chat about the pre-recording and about if anyone would like to opt out the CPT accreditation, there's an email there as well. But thank you all for your time, and we'll let you enjoy the rest of your evenings. Thank you, everyone.
Thank you very much. Bye-bye.
Thank you.
Bye.